Jim.
Thank you, Sharif. And good afternoon. Thank you to Venkatesh Ramaiah for the kind invitation. It's always a great meeting. I'd like to go now looking at PMEG in 2026. Now, I grew up with PMEGs and trying to go through the history and how we have to look at it now. I guess really the first PMEG that we really consider, besides the ironing of Dacron grafts in the 50s, was the group, including Dr. Parodi, that made their first, and this was originally an aortic tube graft for treating aortic aneurysm. That really got us into the whole endovascular era. Dr. Shooter then came back in 2001 with his thoracoabdominal grafts and with Dr. Greenberg, and we're really seeing that these are at least reporting to decreased blood loss, decreased length of stay, and decreased early morbidity and mortality. So what is the role for PMEG? And this is kind of how I went through my early experience. Originally, as I was trying to figure out how it would fit in my practice, in 2003, I went to Europe and actually assisted with some fenestrated grafts because obviously in the United States, we did not have that available. I spent a lot of time measuring and sizing and then going back and saying, how do we use it and how would my measurements work compared to other people that have done their measurements? We did obtain, and I got my hospital to buy a Terra Recon station, and we used that extensively to help with the planning. I then traveled to Australia with Cook for our initial exposure into the Z-fin grafts there, and that was really another learning experience. And I did spend a lot of quality time with Frank Veith discussing the need for an independent board on the trip to Australia. Then we developed kind of this small covert group of U.S. surgeons that started doing PMEG, and this was really a discussion we would have in the back room. We were not really able to talk about it from the podium. We couldn't work with industry on it. And literally, we were kind of in the back. And what do you think about that? Did you have this problem? No, I had that problem. How do you fix it? And we kind of learned from each other, but there was not an open forum or a way of learning how to do PMEG. Eventually, I did go on to get an IDE, which increased my confidence level because now I had, for some of the patients that were not urgent, I was able to get a graft made for it and use that as part of both PMEG, as part of a fenestrated graft and P-branch. And with that again made me more and more comfortable. Then I started doing, for more urgent cases, actually physician-modified grafts themselves. We did have a hiccup in the road, and was the SVS meeting in San Francisco, where Dorothy Abel stood up at the podium and said, I will see anyone doing PMEGs in jail if you continue to do this without an IDE, which tend to get our attention when the director of the FDA makes those type of statements. Then the other thing that came in, so we now have the FDA saying you need to go out and get an IDE, but then CMS in 2015 came back and said, if you do a case under an IDE and it's not going for a phase 2 FDA approval, we won't reimburse you for it. The physicians would not get reimbursed, and the hospitals would not get reimbursed. So if you look at all these disposals, my hospital is not really willing to take that financial loss. And so we had that issue as you went through. And then the hospitals and the risk and the chairs all became risk adverse, and the point that when I went to my next job, the chairman told me, well, if you keep doing modified grafts, I will fire you. So that kind of set, again, the tone and decreased my enthusiasm for PMEGs, but I still had the IDE, and we did more parallel grafts and everything else. But it's kind of been a rocky road to get through this. And here's some of the early physician-modified grafts. I'm sure everyone's seen this, so I'll go through it fairly quickly. 83-year-old patient came in. She was a Jehovah's Witness with a large aortic thoracoabdominal aneurysm, had been seen at little hospitals like Mass General and other places, and was told she was not a candidate for any type of repair, and she needed to get her affairs in order. We were about her third or fourth opinion. She came in. It was a subtle aneurysm, and she was a small woman, so it was about 8 by 13 centimeters as you went through, and it was tender, and you could actually see the point of maximum tenderness right there in the right upper quadrant in that area, 13 centimeters. We did 3D reconstruction and modeling with it, and with this we actually came and figured out how to try and do a fenestrated graft, physician-modified fenestrated graft. She did have an occluded celiac, so we made 3-hole fenestrations. And here's the graft. We had marked it with snare from a endo snare as our marking spot, then came back, reload the graft, and here you see as we're going in through the SMA and then all 4 vessels. With this, we then were able to build up and build down, totally repaired her thoracoabdominal aneurysm, and she went on to live several more years before finally succumbing of comorbid diseases, but not from her aortic aneurysm. So that really got my attention, saying, yes, we should be able to do more of this, and we actually started presenting some of these at local meetings, but could not do it at regional or national meetings. So the next generation of vascular surgeons, how are they learning to do PMEGs? Those, we got out of the back room in the coat closet trying to figure it out. Many of the current vascular surgeons that are early on in the first part of their career have already learned how to do PMEGs, Z-fins, and branch grafts in their training. Anybody that comes through most of our hospitals now are getting these exposures. There's much more industry support. I hear some of the industry coming out, and they actually have complex aortic specialists that will help physicians as they're trying to plan out their PMEG grafts or parallel grafts, wherever the case may be. And I think it's now so being done in so many different places, the genie's out of the bottle, it's going to be hard to come back and say, well, you can't do this anymore. Now, what's going to change things a little bit? The commercially available fenestrated and branch grafts. And so if you come in, I could easily see an attorney coming in and saying, doctor, what is the IFU? Do you have you read the IFU? Does it say in the IFU you can burn holes and do all the things you're doing for PMEGs? And the answer is going to be no. And doctor, is there not an FDA-approved device available? And the answer is going to have to be yes. So I think there's going to be some constraint on this outside of an IDE, and that's only if you have patients that need urgent repair. So the delay in manufacturing is going to be an issue, and you need to make sure you have increasing experience with sizing and planning as you go through. I think we're seeing now that there are other acceptable options we're coming through. The parallel grafts, laser fenestration, again, that is a PMEG, but I think we're seeing more and more acceptance with that. I think we're also seeing better imaging in the ORs. We had one of the first angio ORs, and that was back in 1995, and it was a little 440 square foot room that we were able to build, but it was one of the first. Now I think most major vascular centers will have a fixed room available, if not 2 or 3. I think fusion technology is another way that's going to help us line up our models as we move forward, as we go doing more of these fenestrated and branch grafts. So I think, the other issues we've all talked about, and Dr. Zarin's very nicely outlined, is that if you look at, the long freedom from death in these patients, all-cause mortality, it drops off, but it's not aneurysm-related mortality. These people are sick, they die of coronary disease, and everything else as you go through it. And so what do I see as the future? And this is something where it's become more standardized. And these are slides, and I give credit to Dr. Ben Starnes, as he's got the Trio Fit program. This is not an endorsement for this particular product because it's still under trial, but he's now created a way that you can actually make a model or a sleeve that you put over your graft, come in, you can actually burn the holes with the model that you have from the 3D generated model. They have the markers that you have, they already have those made for you, and they have a very nice system for recapture and deployment. So here you go, you have the alignment, you can mark, it comes as a little kit, and then here it comes in, they're showing how you can use the different markers as you go through, and as it's positioned, then you just simply suture them in place after you've burned the holes there in a prescribed way. Here's the loading of it comes in. You compress the graft down. It's very straightforward. You then come back and put it into the holder. You can remove that, crimp it down, and then you're going to be able to reload it back into the delivery system. So many of us have spent time with umbilical tapes, sternal wires trying to reload this, and I think with these now standardized kits coming forward, it'll be much easier to do these in these urgent cases. I think we are going to have still the stipulation that's going to have to be something where you go in, you get something laser printed and sent to you in 1 or 2 days, not waiting 3 to 6 weeks to have grafts made for us. So I think this is probably the future of what we're going to see coming in. Dr. Starnes did go out, and it's a 19-French system. Here's kind of showing as it pre-constrained, and he presented his original data looking at this. In the Trio Fit, he just had 8 cases. With Trio Fin as one of his other products, it was 7. And basically what he saw was that the length of time for doing his physician-modified graft with his pre-planned system was equal to or equivalent to in the fenestrated grafts as we go forward. and the complication rate was also very similar without added problems. So I think this is probably the future if we're going to try and do PMEGs, where you're going to have some type of more standardized way of doing it. Certainly, I've been received patients came in that have had people attempting PMEGs that may have done it for their once or second time, and they're disasters. So we have to get it trained in a more of a standardized way, and I think this is one of the systems. I'm sure there'll be more that's going to come out and help us do that. So thank you very much for your attention and time.